As I said, we're going to talk about. So here we go with part 2 of the treatment of infection. And as I said, we're going to talk about a specific type of that viral infection that is very important and a huge problem worldwide, and that's HIV. And will then segue over to treatment of common infections that are caused by fungi. So let's get started by talking about HIV. So the treatment of HIV and acquired immunodeficiency syndrome, we know that AIDS is associated with a very specific virus called the human immunodeficiency virus, or HIV. And this is a virus. It starts out with RNA. It's often termed a retrovirus because of that fact. And it attacks very specific lymphocytes, the T4 lymphocytes, that are such an important player and component in our immune system. This is an infectious agent that impairs our ability to deal with infection. It does that by affecting these lymphocytes or impairing their function. If we don't have enough of these lymphocytes, immune function is compromised. And that opens up the body to other opportunistic infections, bacterial, viral, fungal, and so forth, and certain cancers, which speaks to the ability of the immune system to control certain abnormal cell growths. The goal is going to be to keep an adequate number of these lymphocytes functioning. And fortunately, over the last couple of decades, we've developed several strategies to do this. So we're going to take a look now at some of these anti-HIV drugs. We now have 4 major categories. First being the reverse transcriptase inhibitors, where there are 2 subcategories, and we'll see what they are. They're so-called nucleoside reverse transcriptase inhibitors and the non-nucleoside inhibitors. We'll then talk about the protease inhibitors, then the HIV entry inhibitors, and finally the integrase inhibitors. But let's start with the RTIs. Our first group of anti-HIV drugs are called reverse transcriptase inhibitors. They work by preventing the conversion of viral RNA to viral DNA. That's called reverse transcription because we usually do the opposite. We usually convert DNA to RNA. This is backwards. The virus actually shows up on the doorstep of the lymphocyte with RNA. Its first step is to convert that to DNA. If we inhibit or slow that step down, it has a really hard time gaining a foothold, infecting that lymphocyte. And we see there are 2 subcategories of this group. The nucleoside drugs, they act as false substrates. And what this means is the drug substitutes itself for the normal RNA. And the enzyme goes to work on the drug but doesn't get anywhere. I make the analogy, it's like having a puppy that chews up your favorite shoes. If you buy the puppy a chew toy, a rubber toy of some sort, it spends all day chewing on the chew toy and it leaves your shoes alone. The non-nucleoside, the second subgroup, they're much more direct. They block the active site on the enzyme. It can't do its job. It would be like buying a muzzle for the dog, and it can't chew on anything. So these have been major breakthroughs. Let's look at some examples in the next slide. So here's some examples of the RTIs, starting with the nucleoside subgroup. Certainly zidovudine has been the most famous. It was our first anti-HIV drug. Originally called AZT, it's now officially generically known as zidovudine, or by a trade name Retrovir. And there have been other drugs in this group as well, drugs like didanosine, lamivudine, and several others. Then came along the non-nucleosides a little bit later. Delaviridine, you can see some of the trade names, efavirenz, etravirine, and again, other drugs in this group, nevirapine. Both groups together, very important. Let's take a look schematically at how they work and why this is such a critical step in viral to prevent during viral replication. So this is a diagram of the viral cell. And you see the virus showing up on the left-hand side of the diagram. It crosses the cell membrane, it uncoats, and releases its genetic material. But as I said, this is now RNA. Before it does anything, it has to convert this RNA into viral DNA. That's the job of this enzyme, the reverse transcriptase enzyme. And why this is such a key step is once it happens, the viral DNA is spliced into the host cell chromosome. That's why once this virus infects this cell, it's really in that cell. It's actually placed its genetic material into the host cell chromosome. So clearly, the RTIs have a big job here. If they inhibit this enzyme and prevent that key step of creating viral DNA, the virus can't get that foothold. It can't basically insert its genetic code and take over that cell. The protease inhibitors were the second major advancement in treating HIV infection. HIV protease is a key enzyme that's involved in one of the final steps of HIV synthesis. So if RTI inhibits one of the inhibitors inhibit one of the first steps, this group of drugs inhibit one of the last steps. And the protease inhibitors, the drugs themselves, mimic the viral components, and they basically block the ability of this protease to start to assemble the final mature virus. And these often end with that common AVIR suffix. There are several currently on the market. We'll take a look at them in a second, and many are still in development. But this is showing how these drugs work. The pair of scissors that you see in this diagram is meant to represent the actual enzyme, the protease. Its job is to start to chop up these long polypeptide chains that the virus has manufactured into shorter chains that are used to make or synthesize the actual virus. So again, the protease does this. It starts to cleave these long chains into shorter chains that are put together as part of the mature virus. The protease inhibitor, you can see down towards the bottom, the little red structure clogs up this scissor and doesn't allow it to do its job to cut up this protein chain. Not to get too far ahead of ourselves, but in the upper right-hand corner of the diagram, you see that certain enzymes have already become resistant to this. And we didn't talk too much about viral resistance, but this can happen just like bacterial resistance. So we are seeing an example of that. I'll have to come back to that a little later, but that's what this diagram is showing. Normally the protease should do its job of scissoring off these long proteins into shorter proteins, but the protease inhibitor, if it works, it will inhibit that effect. And here are some examples. Again, I said they have this AVIR ending on their generic name, so aprenavir, atazanavir, indinavir, very common, nelfinavir, ritonavir, and several others like that, sequinavir, and a few others. And some certainly will join this group as they are developed and approved. So a pretty nice list and a growing list of this strategy. Our next group, fairly recent, the HIV entry inhibitors. We said in part one of this lecture that viruses have to get into the cell to begin to take over, and they'll find a host cell. They'll often adhere to the surface of the cell. If we can prevent that step, that's a huge benefit. If that virus cannot get into that cell, it can't begin to replicate itself. So these drugs impair the ability of this virus, HIV, to fuse with the surface and enter the host cell, often called the CD4 lymphocyte because it has this specific CD4 receptor that's specific for the virus. So here you see a diagram of that. The virus is the green structure, and you can see it has almost like keys that are specific for a lock on the surface of the T cell, the lymphocyte. The examples of this type of drug are enfuroviritide, Maraviric. The trade names are nice. They tell you a little bit about they're trying to prevent fusion or prevent entry of the virus into the cell. So a small list right now, but again, hopefully a growing list as more drugs are developed that help prevent this very critical step in viral replication. And finally, the integrase inhibitors. Integrase is another enzyme the HIV uses to splice its genetic material into the host cell chromosome. You saw that originally on one of the earlier slides, where after the virus creates its own genetic DNA, it hardwires that DNA into the host cell chromosome. That's done by an enzyme called the integrase. So you see that down here on this diagram, where the drug again binds to the ends of this genetic material, the viral DNA, and it doesn't allow the enzyme to do its job, to put that viral DNA into the host cell DNA. And again, there's not a lot of these right now, but this is a growing list. They have this, again, GRAVIR ending on their generic name. So we'll keep our eyes open for more drugs along that use this process or this strategy to prevent this step of viral replication. So to summarize, we now have 4 major strategies of preventing HIV replication. And each strategy comes at the problem from a slightly different angle. The integrase inhibitors, the protease inhibitors inhibit some of the later steps in the process. The entry inhibitors, the very actually first step, and the RTIs, that critical step of converting RNA to DNA. This is a nice thing because we can use these drugs together because they do all come at this problem from a slightly different perspective. So we often talk about this HIV cocktail that involves more than one of these drugs, and often 3 of these drugs combined, because they will help prevent various steps of viral replication. But we do have to consider the adverse effects. These are serious drugs. Some of them may cause muscle pain, muscle weakness, as well as neuropathy. Probably most common with the RTIs and the integrase inhibitors. These side effects are very important because, of course, we're trying to maintain muscle function. We're trying to maintain neural control of the muscle. So if these are drug-induced side effects, it's really important to us and to our patients. Lipodystrophy syndrome, common in the protease inhibitors and the integrase inhibitors. What this involves is a large gain in body weight, an increase in, especially in abdominal fat deposits, insulin insensitivity, and hyperlipidemia. It almost looks like a type 2 diabetes. This was one of the big limitations when the protease inhibitors were first developed. Patients often did very well on them in terms of their anti-HIV effects, but if they had this lipodystrophy syndrome, it increased cardiovascular risk. So it took away some of the benefit of this drug from some patients. And there are other side effects. Blood dyscrasias, meaning anemias, white blood cell dysfunction, other problems with the formed blood elements. GI distress is common, especially in the initial administration, and immune reactions, and these are true for all groups. So once again, these are serious drugs, often given at a fairly high dose, and often given together, where several drugs are combined in this so-called HIV cocktail. So that's what this is referring to here, the combination strategies, or what we often talk about as a cocktail effect. Another term for it is highly active antiretroviral therapy, HAART. And it can involve many combinations. Sometimes it's 2 nucleoside RTIs and 1 non-nucleoside, but this is highly variable depending on the patient, their needs, and so forth. And other drugs are certainly added or substituted to first of all maintain the antiviral effects, but also to avoid resistance. If you keep throwing the same drugs at the virus over and over again, and we hear a lot about how this virus often mutates, that there's simply more of a chance that that virus will become resistant to that drug regimen. So by changing the regimen periodically, this may help prevent some of that resistant effects. But once again, these often involves 3 or so drugs, complex dosing schedules, and patients do well on these schedules in terms of their anti-HIV effects, but you have to appreciate that again, this is not always easy to do, to stick to the drug regimen as carefully and as closely as you need to. And we do see many other common medications used in people that now have developed AIDS, acquired immunodeficiency, where for whatever reason the drug strategy was not successful, or they did not adhere to the prescribed regimen and have progressed to AIDS. And in this case, we're talking about opportunistic infections, that the body now is open to bacterial, viral, fungal, and other or pathogenic microbes. And these drugs often have to be given indefinitely because as soon as you take the drug away, the opportunistic infection will come back. Also, treatment of cancers. Again, patients that have progressed to AIDS, interference can be helpful in controlling the treatment of cancers like Kaposi's sarcoma. So obviously we want to keep the immune system functioning to prevent the need for these other drugs. But if the patient has progressed or a person has progressed to AIDS, these drugs may almost always be necessary in some version. So where are we in terms of current and future strategies? I mentioned several times, drugs are still being developed to in some way affect HIV proliferation, HIV infection. And we will certainly continue to modify the cocktails, the HART strategies, as newer drugs come onto the market. So ongoing drug development is a real need for this, and it is certainly hopefully going to produce newer and even more effective drugs. But the key question is a vaccine. Will we have an HIV vaccine? This is going to be difficult. You hear a lot about, and I mentioned the fact that this virus is supposedly notorious for mutating. One way I've heard it explained is that when the virus replicates itself, it does a really bad job at this, and that the new copy of the virus is often not quite the same or doesn't look quite the same as the original copy. It'd be like making a Xerox copy of a page of paper that gets blurred in some way. And we'd like the Xerox copy to be identical to the original copy, but it may not be. So if we can develop a vaccine that recognizes one form of this virus, when this virus, because of its sloppy ability to replicate itself, does not look that way anymore, and that vaccine would be ineffective or not as effective. So this is a concern. If we have a vaccine, it has to be virtually 100% effective. Otherwise, people might get a false sense of immunity, and not share and start sharing needles again, or not have safe sex. So a vaccine is going to be very difficult to produce, and we have to hope that this will be done. But you realize the problem, especially with the idea that this vaccine or this virus can mutate. So at the present time, our best strategy is still prevention. It is, in one way, it's difficult for this virus to be passed from one person to another. You need prolonged contact of body fluids or a direct needle stick. So we have to still be vigilant. And this is important because some of the drug strategies we've talked about have become so successful, they can lower the viral load down to where it's not even recognized by conventional blood testing. Patients or people who have HIV infection may think they've been cured. And they'll say, oh, I don't have this virus anymore. They did a blood test. They didn't see it. They're not cured. That virus is still in their body. It's basically hiding inside the lymphocytes. So we have to make sure our patients and our clients understand this, that the drug therapies we currently have do not cure HIV. But hopefully we'll keep the lymphocytes functioning to the point where the person has an immune system.
Press pause and read this slide before proceeding to the next one for the answer.
So we want to leave our discussion of viruses now and focus on a different type of microbe, a fungus. And we'll talk about fungal infections. Another term for this is a mycosis or mycosial infection. And the big question here is, where in the body is this infection? And if it's fairly superficial or fairly localized, we can often treat it pretty well. But if it becomes disseminated throughout the body and becomes systemic, much more serious problem. And this is especially serious in a person who is immunocompromised. Our immune system is often really good at dealing with a lot of funguses within our body. But if the immune system is not functional, these funguses do proliferate, infect lungs, other organs, and other tissues. So we'll come back to this idea periodically. Where's the infection? And if it is fairly superficial, fairly local, we'll see that it often can be treated fairly easily, but maybe not so much if it's systemic. So we see lots of these fungal infections, things like athlete's foot, tinea pedis. We see vaginal infections, the candida infections, those kinds of things, which again are, in both cases here, are fairly localized. Skin infections, localized infection in the vagina. But the problem is the systemic infection here. If this infection has disseminated throughout the lungs, again, much more difficult to treat. So let's take a look now at some of the options we have for treating fungal infections. So we see, first of all, there's a group of drugs that are chemically similar to each other called the imidazoles, and we'll talk about them first. Then we'll talk about a fairly eclectic group of drugs that are also used for other fungal infections. Our first group is called the imidazoles. They tend to have this azol suffix on their generic name. They work by inhibiting the enzymes that synthesize specific parts of the membrane of the fungus. These can be sterols and other phospholipids that hopefully are fairly specific for the fungal cell membrane and maybe not so specific for the human cell. Or the mechanisms, the enzymes that synthesize this component is different in the fungal cell than the human cell. So we're getting back a little bit to this idea of selective toxicity. If these drugs can be fairly selective for the mechanisms in the fungal cell without affecting the human cell, that's a really good thing. But still, their local versus systemic use is determined by toxicity. We'll see that we can use much more toxic drugs superficially. In other words, they're not traveling throughout the entire body, but we apply them locally or superficially. The same drugs cannot be used oftentimes systemically because they're going to be much too toxic to the liver, to the kidneys, and to other organs. But let's take a look at some of the specific drugs in this group now. So some examples of drugs that are used locally are the conazole drugs like butaconazole, clotrimazole, miconazole, and you recognize probably some of these trade names. A lot of these are available over the counter and are used for superficial infections or localized infections like fungal and vaginal infections, yeast infections. Systemic drugs, again, still the conazole drugs, but these are not much better tolerated necessarily, but at least have less toxicity to the other organs that they can be used systemically. And you can use these systemic drugs locally. In other words, they are not so toxic that you can't use them systemically. You can use them and go throughout the entire body, and clearly you can also use them locally, but it's not true the other way around. You oftentimes cannot use the local preps systemically because they simply are going to be too problematic with side effects and other toxicity. But you recognize again some of these trade names, fairly common drugs. That was our group of imidazole drugs. There are other antifungals that are classified according to their chemistry, and same thing, they generally impair the membrane integrity or the simple biochemistry of the fungal cells. Once again, focusing on maybe some unique aspect of the fungus that's different from the human cell. But we still have that same restriction of how toxic are they? And if they're too toxic to be used systemically, they are restricted to local use. So we see drugs like amphotericin B, which is perhaps one of the most common antifungals used especially for systemic infection. Other drugs, griseofulvin, nystatin, very common drug, terbinafine, what else? Tolnafdate, again, pretty common over-the-counter product. So once again, some of these can be used systemically, some of them cannot. This diagram summarizes some of the common antifungal mechanisms. You can see that some drugs like amphotericin B, nystatin, affect the formation of sterols. Others affect the like the azole drugs, fluconazole and so forth, affect the formation of the membrane sterols. Others affect an enzyme called glucan synthetase, which is an important enzyme that makes certain components of the membrane. Others actually affect the mitosis of the fungus. Griseofulvin is a good example of that. So they don't all work the same way, but you get a sense that they're all trying to disrupt this integrity of the cell membrane or the production of the cell membrane components or simply the division of the fungal cell, and hopefully in a way that's different enough from the human cell that they can be useful without extensive side effects. But still, we are faced with the issue of antifungal problems and adverse effects. If these drugs are used topically or locally, there's usually few serious side effects, but we don't want to overuse them either. They should not be used preventatively. In other words, a person who's worried about getting athlete's foot shouldn't preventatively spray their foot with an antifungal, a topical antifungal that simply sets us up for resistance. So they're often very effective and should be used and used as directed for the treatment of acute fungal infections. Again, either skin infections like athlete's foot or the tinea capitis, the scalp infections, and so forth. But really not overuse them and don't use them indiscriminately for other types of infections. When they are used systemically, much more serious problems. Headache, GI problems are common. Other really serious effects on the liver, hepatotoxicity, blood dyscrasias in terms of red and white blood cell formation can be very serious and even life-threatening. So once again, fungal infections are fairly easy to treat until they disseminate throughout the body. Then they're much more problematic, especially in the immunocompromised patient. So that finishes our discussion of infection. Once again, we haven't talked about all the different types of infections that can occur in our patients, such as some of the protozoal infections and helminthic or worm-like infections. But at least I think you got a sense of some of the more common drugs we may see in our practices and how these drugs work.